Welcome to Chapter 21, Resuscitation for the EMT. So, some pathophysiology. The function of the heart is to pump blood. We have electrical functions and mechanical functions, and they have to work together. Electrical stimulation causes the muscles to contract, and then the pumping that contraction causes pumps blood around the heart. But that muscle also requires oxygenated blood that we get through those coronary arteries that we talked about in the last chapter. So without that oxygenated blood, then pumping eventually fails. Okay. So we have a couple different types of failure to go into cardiac arrest. We have mechanical failure of the heart, where we have loss of muscle from like a myocardial infarction or chronic hypertension. You also have loss of normal heart valve function, where the heart valves don't function properly. The heart valves are supposed to just allow the blood one way in, and so that way it doesn't backflow. But when you have loss of that, then you start to get your heart just doesn't work as well. And then you can have some direct trauma, such as like pericarditis or cardiac tamponade or anything like that. And then PEA, or pulseless electrical activity. You can also have some type of electrical dysfunction. So that cardiac conduction pathway just kind of goes into an erratic rhythm, like pulseless VTach or VFib. Those are the two things that will make the heart go into a cardiac rhythm, cardiac arrest. Now, everything else can lead up to that if it's not fixed in a timely fashion, can lead to those things. So anything to do with the heart really just needs to be fixed as soon as possible. Asystole, this is that flat line that you see on TV shows, and it's just a complete failure of that system. Dysrhythmias, so we talked about these in the last chapter. There's a bunch of them. They can be unusually slow, unusually fast, and then VTach and VFib. Okay, VFib and VTach are correctable. You shock them with electricity, and they should convert and go back into normal rhythm. Sudden cardiac arrest. So this is an abrupt onset of dysrhythmia. There was nothing leading up to it. There was no chest pain. There was no anything like that. Or there may have been, and they just ignored it, and then they went into cardiac arrest. It can be caused by acute blunt trauma to the chest, such as commotion cordis. This is typically happens when softball players get hit in the chest with the softball, or baseball players. Typically softball because it's a bigger ball, but they can get hit in the chest. And if you watch those medical TV shows and they hit their fist on the chest, that's really what they're trying to fix, is this commotion cordis. And in sudden cardiac arrest, their oxygen levels are relatively normal at the beginning. In asphyxial cardiac arrest, the heart has stopped because of systemic hypoxia, because of low oxygen levels in the blood. It does appear with some a little bit more warning than a sudden cardiac arrest, and then just make sure that you have quality ventilations while you're doing CPR. If you think it's a respiratory problem. So agonal respirations, this is agonal breathing with a primal reflex during cardiac arrest. It's not enough to sustain life. Um, it doesn't allow enough oxygen into the brain, and it doesn't allow enough oxygen to keep the organs alive. Um, and unless we intervene, then the patient will um, spiral into death. Um, so effects of cardiac arrest, so the heart fails to pump, blood stops moving, the cells are then robbed of the essential oxygen and nutrients, the organs are damaged, they eventually fail, and then the organism itself will die if it's not corrected. The goal is to intervene as soon as possible. Pediatric cardiac arrest, these are typically respiratory in nature or asphyxia in nature. It is caused by choking, shock, or some type of respiratory problem. And it's usually a predictable outcome after steady decompensation. So when we do a patient assessment, we typically um, are only focused on the patient. Um, Whereas there's other things going on, and you have to have your situational awareness because it's a cardiac arrest. Yeah, I mean, the patient needs something, but you got to use your situational awareness. Okay. So in our primary assessment, we want to identify these three key features of cardiac arrest, and that is unresponsiveness, apnea, and the absence of a pulse. So um, after all of that and cardiac arrest has been identified, we're going to start chest compressions immediately. When we go to when we do our primary assessment, though, typically in a responsive medical patient, it's ABCs, so airway, breathing, circulation. When we know that we're going on a cardiac arrest, or we figure out that it's cardiac arrest first, we're going to do CAB, so circulation, airway, and breathing, or compressions, airway, and breathing, to fix this. SIDS, or sudden unexpected infant death syndrome. Um, there's a couple different causes. So it could be SIDS, the sudden infant death syndrome, where there's um, no known cause or anything like that, and it typically happens. In SIDS kids, the unfortunate thing is that we typically don't get these kids back. Mainly the reason because by the time that that mom and dad or caregiver realizes that they're not breathing, they don't have a pulse or anything like that, um, it's too late because it's overnight while they slept. Uh, and then sometimes there's just an unknown cause that causes sudden and unexpected infant death syndrome. And then they could also have accidental suffocation and strangulation. Um, Again, this is why we tell people not to put blankets or pillows or, um, you know, stuffed animals in bed with kids because they can suffocate and strangle. And also why we tell parents not to sleep with their kids. Typical SIDS patients, they have a cardiac slowdown and sleep apnea. They'll eventually stop breathing and not start again. And then the episode will be fatal to the infant if they're not reached in time. So unless the kid has the kid has rigor mortis, then we're going to start resuscitation. And we're also going to provide emotional support to the parents. We're not going to blame them. We're not going to say, if you had done this, your kid would still be alive. No. Because they're already going to be blaming themselves for this. And they're going to be very upset. All right, so improving cardiac arrest survival. So there are 5 elements to the chain of survival: recognition and activation, immediate high quality CPR, rapid defibrillation, basic and advanced EMS, and advanced life support and post-arrest care. And then we also add in teamwork and coordination to this. When we add in these things, it's that when we add in teamwork and coordination, we bring in all of those elements together in order to give the patient the best chance of survival. So link 1 is recognition and activation of the emergency response system. So efforts should and must begin before the arrival of the EMTs. So we want to train citizens to recognize a cardiac arrest, activate EMS, and begin resuscitation. There are several different programs out there. AHA just happens to be the biggest one out there. But in schools, in Missouri at least, high schoolers, before they graduate, have to have at least 30 minutes of CPR. Do I think that's enough? No. But is it something? Yeah. So it's something to do and something to just be aware of. And then when we go to various things in the public, so maybe you've got some type of you go on to do a standby for some type of event, and it's not an event where you have to be like I don't know. I guess a good example is around our area we have Jacob's Cave. It's a huge flea market. It happens like twice a year. And there's lots of vendors, lots of things out there. And what they do out there is they have an ambulance on standby. And they bring in an ambulance, and that ambulance is there for medical care. But not only that, while they're there, they do some public relations. So they can have a CPR mannequin out there. They can teach people, push hard and fast on the chest when a patient is in cardiac arrest. So, and of course, after that, then all of the dispatchers and stuff like that are trained to guide people through CPR and how to do it. Push hard and fast on the chest, 30 to 2, blah, 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 all of that thing, all of those things. And there's a lot of EMTs and paramedics who are CPR instructors. So that's just one way to participate in public CPR training. Some people do it for free. Some people do it as business. It's just kind of there. Okay. Link 2 is immediate high quality CPR. So cardiopulmonary resuscitation, CPR, it moves blood through the cardiovascular system. We have to maintain cerebral and coronary perfusion pressures. So cerebral and coronary perfusion pressures is basically how much blood needs to be pumped to the brain in order to make it work, and how much blood needs to be pumped to the heart in order to make it work. Okay. Hand placement, so we're going to go the lower third of the patient's sternum. On adults, it's the heel of one hand on the center of the patient's chest and the heel on the top of the other. In children, it's the same as an adult, but second hand may not be needed. And then in an infant, we have one rescuer where we do 2 finger compressions and 2 rescuers with a 2 thumb encircling hands. Okay. Depth, So we're going to compress at least 2 inches for adults. We're going to allow for a full recoil on the upstroke of those compressions. We're going to spend half of each compression on the downstroke and half on the upstroke. For infants and children, we're going to compress 1/3 of the anterior posterior diameter of the chest. If you remember it, it's going to be 1/3 the depth of the chest for anybody. Okay. Hands should overlap with interlocked fingers. Elbows should be locked. Weight of the shoulders should drive the compression. Pivot point should be the waist, not the elbows. And compress no longer than 2 minutes and switch with another provider. Compression rate, so we're going to compress at least 100 to 120 times per minute. You're going to compressing too slowly does not generate adequate cerebral and coronary perfusion pressures. And compressing too rapidly does not allow the heart to refill. So the 100 to 120, if you can remember songs like Staying Alive, Another One Bites the Dust, Cardi B's WAP is another one, and Baby Shark. All of those songs are timed at about 100 to 120 beats per minute. Minimize your pauses and compressions. We're going to aim for a compression fraction above 90%. So that means that our time off the chest and our time on the chest is 90% more on the chest than off. Okay. Take steps to avoid pausing chest compressions and initiate chest compressions immediately upon arrival. And then clear all rescuers during the analysis phase of the AED. Pre-planned compressor change out to avoid delays. Typically what you're going to do is while the patient's breathing, while somebody's breathing for the patient, you're going to then switch compressors at some point right there. Minimize the urgency of transport in the initial phase. We typically do not transport any patients now for cardiac arrest because there's nothing that we're not going to do at the house that the ER is going to do any differently, other than have a bigger team to be able to do the cardiac arrest. But yeah, so we're not going to transport just because it's a cardiac arrest. We're going to we're going to work the code as it comes. And then train with the tools of resuscitation. So, if we've got a Lucas, we're going to train with it. An automatic vent, we're going to train with it. Just take those into consideration as well. Okay. Rescue breathing. So ventilation should be integrated at a ratio of 2 ventilations to 30 compressions. In pediatric patients with 2 rescuers, you're going to adjust the ratio to 2 to 15. And there's some protocols out there, Mercy protocols, don't necessarily go off of AHA. We go off of a more advanced life support type CPR, I guess, but it's not this specifically. So there are some mechanical CPR devices out there like the Lucas, what I was saying. So basically what a Lucas is it does the compressions for you. It's a device that you apply to the patient and it does the compressions for you. The Zoa AutoPulse. So this one is a little bit different. Instead of a plastic plunger type deal with Lucas, the AutoPulse actually wraps around the patient and it pulls the chest in instead of compressing down on the chest. Link 3 is that rapid defibrillation. So to achieve that successful resuscitation, the heart must begin pumping again. So we're going to use that AED to correct any kind of life-threatening dysrhythmia. Okay. So an AED is two devices in one. It has a sensor to recognize VFib and VTAC, and it has a defibrillator to discharge energy through the electrodes and into the patient. Okay. Most common conditions resulting in cardiac arrest are shock rhythms, so VFib and VTAC. There's two different types. There's the monophasic and a biphasic. Typically, your AEDs now are biphasic, meaning that they send a shock in one direction and then they send it back to the other side. Monophasic sends a signal from the positive to the negative pad, or from the negative to the positive pad. Link 4, basic and advanced life support. So quality compressions and rapid defibrillation is basic life support. And that's really what's going to save your patient. It's not going to be the advanced procedures and medications that I do. Those are just helping. But it's the quality compressions and rapid defibrillation that's going to save the patient. So there's this triangle of life where we have one provider delivering compressions, one provider attaching the AED, and one provider managing the airway and delivering ventilations. Okay. The team leader may add advanced life support outside the triangle if additional providers are present. I'm going to show you a picture. Well, I thought I was going to show you a picture, but apparently not. I think it's a little bit later. Moving on. Advanced life support and post-arrest care. So this is link 5. Coordinating numerous means of assessment and interventions that together maximize the chance of neurologically intact survival. You want to make sure that you recognize the return of spontaneous circulation, so the heart beats again, or the patient starts breathing again, or there's signs on your monitor that the patient has a pulse. And there's various things like that, like I think we talked about back in vital signs and respiratory that CAPNO, capnography. If you see a sudden spike in capnography, it typically means that you've got some type of return of spontaneous circulation. You're going to initiate transport to the hospital. Not immediately, but you're going to do it, okay? Mainly because when you immediately transport a patient to the hospital, that patient is likely going to go back into cardiac arrest because we've moved them too soon. So you want to stabilize them. So what can you do to stabilize them? Or what can you do to make sure that they don't go back into cardiac arrest? So advanced life support, there's some things that we've got to get done before or immediately after the return. So blood pressure, full set of vitals. We want to manage the airway if we need to. So ALS could probably intubate the patient or take out the iGel, switch it out fairly easily in order to secure a good airway. Make sure that we have good ventilations and make sure that our we can give drugs to help with the blood pressure, and because the patient's blood pressure is not going to be great, so we can give some medications for that. We can obtain a 12 lead, and basically you want to wait a little bit before you just start moving your patient. Okay. So management of that cardiac arrest. So we're going to perform one rescuer and team-based CPR. You're going to take standard precautions. You're going to use an AED. You're going to request ALS as soon as possible to continue the chain of survival. and you're going to use a back valve mask with oxygen. Lift and move patients. If your patient is in an area where you can't perform good quality CPR, then move your patient, because I'd rather take the time to move my patient to an area where I can get to them rather than leave them there where they are and not be able to do good quality compressions. Okay, use any kind of adjuncts, suction the patient's airway if needed, and interview the bystanders and family members, because you need to know what's going on with that patient. A coordinated resuscitation team. So we're going to switch roles as compressors to avoid fatigue. Be sure that you have appropriate personnel on hand and integrate both BLS and ALS care. Facilitate that teamwork, assign a team leader, and coordinate actions using a pre-resuscitation huddle. Okay, so I mean, you kind of fall into that team based on your provider levels. So, you know, anywhere you go, that paramedic's probably going to be the lone ALS provider on scene. So they're going to be the team lead. And then, you know, and then it just kind of falls into place once you start doing more codes and doing that. Okay, so the steps of resuscitation, these steps ensure that the key elements of cardiac arrest are being provided. The sequence may be different depending on the resource availability, and we're just going to tailor those steps to meet the needs of the situation. Okay, so step one, identify cardiac arrest and begin resuscitation. All right, so identify the cardiac arrest patient, organize the team, appropriate resources, begin chest compressions, and do not let the patient move the patient unless necessary. Again, move your patient if they're in a place where you can't get good quality compressions. Integrate the AED. We're going to attach the AED and use it. Okay. I am not going to go into a whole lot of detail with these because most of these things you did or should have done or will do during your BLS class. Okay, so you're going to integrate the AED, you're going to turn it on, and then the AED is going to assess your patient, and it's going to look for that VFib or VTAC. If the patient doesn't have either of those, it'll tell you that there's no shock advised. Or if it is in one of those, then it's going to tell you that the patient is shockable or shock advised, and you're going to clear everybody and push the shock button. Okay. You're going to continue the resuscitation, so focus on high quality teamwork. Integrate additional resources as they arrive, and for the 2 minutes between analyzations, you're going to perform CPR and offer advanced life interventions as appropriate. Okay, and then prepare for your next defibrillation. If resources are available, we're going to obtain patient information like a patient history of present illness. So what were they doing before this happened? Were they complaining of anything? Anything like that. And then you're going to do your secondary assessment and review any kind of physical findings. Okay. So should the family watch the resuscitation? This is completely up to the family on whether or not they want to watch. I give them the opportunity to watch if they want to. If they do decide to watch, I want to put somebody with them if I have the available people to put with them. To kind of explain what's going on, what we're doing, how we're doing it, so that way they're not freaked out. If I don't have that availability, or the patient doesn't want anybody to, or the family doesn't want to watch, they'll typically go in another room, and I will go in and update them as needed. and as I'm available. So if resuscitation is successful, we're going to shift to post-arrest care. We're going to focus on rapid appropriate transport. Again, waiting 10-15 minutes and then transporting is standard of care now. Okay. Airway management and then access to ALS. We're going to check a pulse every 30 seconds. If there's no pulse found, you're going to stop the vehicle, start CPR, analyze shock, continue with shocks, separated by 2 minutes of CPR. Terminating resuscitation. So once you start resuscitation, you must continue until one of the following occurs. Okay, you either get a pulse back, okay, or you get a pulse and breathing, or another trained rescuer can take over for you. So, or you turn care over to the patient over to a person with higher level of training. You're too exhausted to continue, or you receive a cease resuscitation order from a physician or other authority per local protocols. So, our protocols at Mercy require us to call for a doc to stop resuscitation. So we call med control and say, this is what we've got, this is what we've done. We've been going at it for about 20 minutes and haven't had a change in rhythm, so I want to stop CPR. And they'll typically tell you, yeah, that's fine. Okay. Or they may give you ideas on what to do. They may have, they make big bucks, so they're a little bit smarter than me, and they know more things than I do. So they may be able to say, hey, this is what you've got. We might try this. Okay. Death notifications. So if we're going to notify the family of an unsuccessful resuscitation, we want to be straightforward, use direct language, allow the family time with the deceased patient if possible, take the time to be with the patient, and be patient. Do not suggest that you know how they feel. You can say, I can't imagine how this feels for you, or various things like that, but don't say, I understand how you feel, because you don't. You don't know how they feel. This is a completely different situation for them, completely different life circumstances for them, so you really don't know how they feel. And be yourself as well. Special considerations. We're going to coordinate with others who defibrillate before you arrive. So let the operator of the AED complete the shock before you take over care of the patient. You may need to take the first AED to the hospital with the patient so data can be retrieved, and protocols are going to dictate how you transfer care. So resuscitation in the ambulance. The initial steps of resuscitation in a moving ambulance should be avoided. If the patient goes into cardiac arrest during transport, stop the vehicle and perform CPR and deploy the AED. We've transported patients and done CPR. It's not safe, I'll admit, and they don't suggest it, but it's been done. It will probably continue to be done. And I mean, we've done CPR going down the road. The Lucas devices make it a little bit more easier because you can just place the Lucas device on and you don't actually have to stand or do anything like that to perform CPR. Okay. Cardiac arrest care for hypothermic and submersion injuries. So you're going to attempt defibrillation once in a hypothermic cardiac patient, and wait until the core temp is at least 86 before attempting to defibrillate again. Do not terminate resuscitation in the field for hypothermic patients. There's a saying in EMS, they're not dead until they're warm and dead. Okay. Submersion injury. with cardiac arrest is the same as any other cardiac arrest patient. Be aggressive with airway management, rescue breathing, and take any kind of precautions to make defibrillation safe for your team in a water environment. Obviously, pull them out of the water, dry them off. It doesn't have to be like super dry, but they need to be, wiped down at least. Okay. Don't defibrillate that soaking wet patient. Dry their chest off and move them out of the wet environment. Remove any kind of medication patches to prevent burning as well. Implants and surgeries. So defibrillation can be performed on a patient with an implanted device. We're going to position the pads on the patient's chest to avoid contact with the device. Again, 2 inches apart, or I'm sorry, 2 inches away from the device itself. Typically, you're not going to run into anything major. So some things that you may run into are cardiac pacemakers, implanted defibrillators, ventricular assist devices, cardiac bypass surgery. You may also run into a life vest that basically is an external AED on the patient that they wear all the time. So if you have any questions, let me know, and we will answer those as I can.